Hi, my name is Sandra Ruiz White, and I'm going to be starting our group presentation. We're focusing on Chapter 7, Post-Traumatic Stress Disorder. We decided to focus on children and adolescents since our chapter was very lengthy and had an abundance of information. We hope you enjoy. Post-traumatic stress disorder, brief history in children and adolescents. In 1980, PTSD was actually recognized as a disorder with specific symptoms that could reliably diagnose and was added to the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders. However, at this time, this did not include criteria for children and adolescents, so we did not have data that was necessarily reliable. The Diagnostic and Statistic Manual of Mental Disorders, the 5th edition, the DSM, was the first one to have specific diagnosis and criteria for children under 6, and then a specification for children and adolescents. This edition now includes guidelines for diagnosing PTSD in children and adolescents. However, to be identified as having PTSD, they have one thing in common, which is that the person or child must meet conditions and symptoms as specified in the diagnostic manual. And the first criteria is that the child must have been exposed to a child or adult must have been exposed to the trauma in which he or she was confronted with an event that involved actual or threatened death or serious injury or actual threatened sexual violence. Following this, there's a lengthy criteria that follows. However, there's 8 categories that include symptoms, stressors, and durations of symptoms. Unfortunately, due to our time constraint, we won't be able to go through these. My group and I would like to highlight what occurs during trauma in PTSD in children ages 6 and adolescents. If trauma occurs during early developmental stages, there's a dramatic shift in the brain's functioning and from being inquisitive, exploring, and learning mode to a reactive and defensive survival mode. This damage usually occurs in 3 specific areas: emotional dysregulation, which can be categorized by emotional emptiness or constant distress. This is an example of this would be long terms of sadness, anxiety, and so on. Disassociation, which manifests as a mental disorientation and confusion. Hyperarousal, which is physically draining to the body to the point of exhaustion. This is when a child's brain is on full alert of flight or flight. It could be very exhausting physically and emotionally.
My name is Philip Walcott, and I will discuss how post-traumatic stress disorder, PTSD, might manifest and show up in biopsychosocial contents amongst children and adolescents. Whether a child or teen develops PTSD depends on many factors, including the severity of the trauma, how frequently it occurs, and how family members react to the event. A child or adolescent with PTSD feels that they are unable to escape the impact of the trauma. They try to avoid people or situations that remind them of the event. Sometimes they will experience memories or flashbacks of the event, or they may have nightmares about it, feel very real. These constant reminders make living day-to-day life a real challenge, especially for young people who might struggle to express what they're feeling and experiencing. Unlike a rash or broken arm, PTSD can be tough to identify, especially when it happens in your own mind. Though it can look and feel like depression or rage, PTSD is different, and it can affect everything from the way you sleep to your relationships. The impact of traumatic events on children is often more far-reaching than trauma on an adult. Not simply because the child has fewer emotional or intellectual resources to cope, but because the child's development is adversely affected. If an adult suffers trauma and a deteriorating in functioning, after time, when a person heals, he can generally go back to his previous state of functioning, assuming that he has not done serious damage to his relationship, studies, and work. A child, however, will be knocked off his developmental path and after healing from the trauma will be out of step with his peers and school demands. He will therefore suffer ongoing frustration and disappointment even when he has healed from the trauma. Common PTSD symptoms in children and teens: avoiding situations that make them recall the traumatic event, experiencing nightmares or flashbacks about the trauma, playing in a way that repeats or recalls the trauma, acting impulsively or aggressively, feeling nervous or anxious frequently, experiencing emotional numbness, having trouble focusing at school. It's normal to have upsetting memories, feel on edge, or have trouble sleeping after a traumatic event. At first, it may be hard to do normally daily activities like go to work, go to school, or spend time with people you care about. But most people start to feel better after a few weeks or months. If it's been longer than a few months and you're still having symptoms, you may have PTSD. If diagnosed with PTSD, the symptoms in children and teens can look differently than those in adults. In addition to symptoms, we now know that there are clear biological changes that are associated with PTSD. PTSD is complicated by the fact that people with PTSD often may develop additional disorders such as depression, substance abuse, problem of memory and cognition, and other problems of physical and mental health. These problems may lead to impairment of the person's ability to function in a social or family life, including occupational instability, marital problems, and family problems.
Hello, my name is Torrin Phillips, and I'm going to talk about trauma-focused cognitive behavioral therapy, or TFCBT. TFCBT is a structured short-term treatment model. It's a therapist-led treatment requiring weekly sessions with a parent and child for about 3 to 6 months. The primary goal is to reduce PTSD symptoms among children and adolescents. A central focus of TFCBT is to ensure an approach that is developmentally appropriate for the needs of children and their caregivers. The trauma narrative component is a critical component of TFCBT. Standard TFCBT is 12 90-minute in-office therapist-led sessions provided to the child with active caregiver involvement. Consists of the following 3 treatment models or phases, each provided to children and parents. 1. Skills building components to enhance children's affective, behavioral, biological, and cognitive self-regulation, and parenting interventions to enhance caregiver coping, behavior management skills, and support to the child. Gradual exposure to the child's trauma reminders is also included throughout these components. 2 is the trauma narrative, during which children describe and cognitively process their personal trauma experiences. A gradual exposure and cognitive processing exercise that creates the individual's story about the abuse. It's shared with the caregiver in the session, allowing them to provide support and help them correct distortive thinking. And 3, treatment closure, including conjoint caregiver-child sessions and safety planning. Typically, 1/3 of TFCBT treatment is dedicated to each of these modules. The major purpose of the TN is to provide more intensive exposure work. This builds on the desensitization process that has been initiated with the skills-based components. This includes a developmentally sensitive assessment and fostering of coping strategies to help children better manage trauma-related distress and emotional reactions. After children learn coping skills, they participate in exposure-based components of treatment. The 5 core elements of the TFCBT model are psychoeducation and parenting skills, relaxation, affect modulation, cognitive coping and processing, trauma narrative, in vivo mastery of trauma reminders, conjoint child caregiver sessions, and enhancing safety and development, or practice. TFCBT improves outcomes in about 8 to 25 sessions. Currently, 21 randomized controlled trials have been conducted in the US, Europe, and Africa comparing TFCBT to other active treatment conditions. All of these studies have documented that TFCBT was superior for improving children's trauma symptoms and responses. Robust findings indicate that TFCBT reduces PTSD symptoms over time compared with control groups and other types of cognitive behavioral interventions. This is the primary goal of the intervention. Also, the trauma narrative component seems to be particularly important in effectively and efficiently reducing a child's abuse-related fear and general anxiety, as well as alleviating parental abuse-specific distress. Thank you very much.
My name is Luis Torres, and I will present some of our recommendations to service providers using the guiding principles of trauma-informed care. First recommendation is to develop a peer support component. This will require hiring young adults who are former clients and their parents to work as peer staff within the program and agency. This practice would send a powerful message to the youth and their families that recovery is possible and that treatment can help. Since parent involvement is a crucial part of this treatment, the parent support staff can also encourage participation of new parents. Peer staff can also help develop support groups for parents who might be re-traumatized during the process or in need of self-care. Peer staff should also be integrated in every phase of the treatment model. Peer staff can help explain the treatment when necessary to families and assist them in make the transition between components. Last part of this is to train peer staff to offer case management services to the families. Examples of some of these services are the following: to help link clients to helpful community programs, also to offer coping techniques to the family between service appointments if necessary. Finally, peer staff can offer follow-up services to former clients. Next recommendation is to increase collaboration with clients. First is to allow parents and youth to participate in planning committees and advisory boards. Clients are the most informed of what works in treatment modules and what needs modifications. Also, recognize youth and their families as the experts of their experience and take advantage of their insight or advice that they can provide. Next is to provide peer staff and clients an opportunity to participate in the training of current and new staff. Clients can help explain their obstacles and experience better than anybody and should be allowed to share their stories with program staff and offer recommendations. Finally, look at clients and their parents as equal partners during the treatment module. Client engagement can improve on program outcomes and ensure continued participation throughout the treatment module. Next recommendation is to empower the client during the treatment and allow them to have a voice. First way to do this is to develop engaging and team-building activities between the client and peer staff so that they can learn to voice their opinion during the treatment. New clients will be empowered to share their input or voice during the treatment if they see that their peers are now valued employees of the program. Next is to allow for some flexibility in the pace or sequence of components. Every client has different strengths and a unique experience. They will respond to each component in different ways than previous clients. These service providers needs to recognize that. Also, agencies need to be aware of the youth clients that they can be re-traumatized or triggered during assessment process or psychoeducation component, and they should be allowed to have voiced their reservations. Agencies should be flexible with the treatment module and allow for clients to change the sequence of components of the module if necessary. Finally, the program should teach youth and their parents some basic coping techniques before they revisit the source of their childhood trauma. Survivors of complex trauma might have internalized their experience for many years or not have discussed their trauma ever, and could be triggered by revisiting their experience.
Hi, my name is Irina, and I will cover the rest of the TAC principles, which include safety, trustworthiness, and transparency, and cultural, historical, and gender issues. According to the safety principle, all parties involved in treatment should feel psychologically and physically safe. This can be achieved through several ways. First, clients should have an option of choosing the therapies that will make them feel at ease. This includes both caregivers and children and adolescents. While some caregivers tend to be extra proactive and decisive over the choices of their children, it's important to consider child's needs as those of the client who receives treatment. Second, counselors should encourage client feedback on behalf of not only caregivers as primary responsible parties for minors, but children and adolescents as well, thus making them feel appreciated and respected. Third, it's important for counselors to thoroughly go over the informed consent in order to facilitate mutual understanding of expectations of both parties for the treatment. By encouraging an open discussion of concerns that may arise when going over the informed consent, counselors are diminishing uncertainty level, thus facilitating the feeling of psychological and physical safety of all parties involved. According to the trustworthiness and transparency principle, counselors and organizational operations and decisions should be performed with transparency, setting trust building and maintaining processes as one of the primary goals. This can be achieved by doing the following. First, as mentioned in the previous section, the informed consent should be thoroughly discussed with clients. By encouraging an open conversation and facilitating feedback, counselors create the feeling of transparency and trustworthiness among both parties. Second, counselors should openly discuss associated potential treatment risks, such as only partial recovery, temporal worsening of symptoms, personality change and resulting interpersonal issues within the family unit, unbearable psychic pain, social rejection, elevated feelings of revenge, inability to accept the imperfect world and or oneself and resulting fallback into PTSD, and other emotional pain that may be facilitated by treatment. By being transparent about potential treatment risks, counselors facilitate the feeling of trustworthiness in their clients. According to the TIC principle related to cultural, historical, and gender issues, counselors and organizations should not reinforce cultural stereotypes and biases, should offer gender-responsive services, be attentive to the culture-specific practices recommended by clients, as well as recognize and address historical trauma. This can be achieved by doing the following. First, counselors and organizations should be active agents of social change through resisting prejudice and microaggressions by actively practicing frequent self-reflection and assessment of their own attitudes, speaking up against perpetrators of prejudice, and facilitating welcoming and trustworthy atmosphere during sessions. Second, gender-responsive services should be offered. Gender-responsive services mean acknowledging and understanding each gender's life experiences and the impact of living as a representative of the gender in a male-based society. However, it is important to stay alert of potentially arising discourses that might be stereotypical in itself, such as believing to know what those experiences are for everyone. While such services are programmed to be gender responsive, it is still important to remember that each individual is unique, thus looking at the situation through a critical lens. Third, counselors should facilitate the inclusion of culture-specific practices and treatment. It does not mean that counselors are obligated to follow clients' lead and blindly adhere to their beliefs without deconstructing them. Instead, counselors should stay attentive to culturally based needs and suggestions of clients with the possibility of its inclusion in the course of treatment. Fourth, counselors should recognize and address historical trauma. Particularly, counselors should put aside their own views on the historical events and recognize the influence of the trauma on clients. Furthermore, such influence should be evaluated during treatment, which may require counselors to do extra research on the subject. Frequent temperature taken and checking in to confirm mutual understanding of the event is crucial to successful treatment outcome. Last but not least, it is worth to mention that some may question the techniques of trauma-focused CBT as it evokes thinking about and remembering scary events in children and adolescents. However, this type of approach was proved to be the most effective one when treating that population with PTSD. In our opinion, that transparency and trustworthiness TAC principle is thus crucial to successive treatment outcome as clients get informed about potential risks in advance. Thank you very much, and we hope you enjoyed viewing our presentation.